right, so now we're going to talk about management of patient with hepatic and biliary dysfunction. It includes the disorders of the various hepatitis, or it's the inflammation of the liver and the most common blood-borne pathogen in the United States. Cirrhosis is the scarring of the liver, and most common reason is usually alcohol ingestion. And we will talk about the different gallbladder diseases, cholecystitis, cholelithiasis. Next slide. This is a nice review of the hepatic and biliary system. Clearly you can see the liver, which lays mostly to the right side and extend over to the left. So right upper quadrant and epigastric area, you could identify the liver there. You also see the little green thing, or that's a gallbladder, and then you see the pancreas that is laying. You see the ducts, see how green, and it travels into the intestine, and then also the pancreas. You see the liver has its own supply, and we're going to talk about some of the wonderful properties of the liver. It's artery and vein, and you'll see why someone has heart failure, for example. You will see a distension or pain to the right upper quadrant. Next slide. So there are some questions that you should understand by the end of this the audio, the role that the glipsin capsule plays, and the mechanical, the clinical manifestations that occur when the patient has a distended bladder. Next slide. So the liver has a dual blood supply, which is really, really nice, right? So it has its own portal system. So there's hepatic vein, which drain the liver and empties into the inferior vena cava, about 1,000 to 1,200 mLs a minute. So very rich in nutrients, right? And you have the artery, hepatic artery, which is drains or flows 400 to 500 mLs per minute, and it's oxygenated blood. You know that artery carries oxygenated blood, and vein carries non-oxygenated blood. Next slide. So the portal vein receives about 1,050 mLs a minute from the spleen, the intestines, the pancreas, the stomach, right? In completely saturated, supplies 67% of the oxygen needs. It empties into the inferior vena cava, and it stores 450 mLs that can be shifted in times of stress. So this is critical because the liver is a site where metastasis can happen because of how all the blood supplies, would touch it. Next slide. Before we talk about the overview of liver pathophysiology, let's talk a little bit about the function of the liver so you can fully understand. So the liver participates and is responsible for metabolism of carbohydrate, protein, and fat. It synthesizes plasma protein. It stores vitamins and minerals. It forms blood clotting factors. It detoxifies drugs and toxins. It produces and excretes bile and regulates hormone function, right? It acts as a reservoir for blood volume. So it's also part of the immune system. So very, very, very important organ. So you can appreciate if something happens to it, all the issues that can occur from this description of function. All right, so now the overview of the pathophysiology. Well, there's inflammation, right? Because we said hepatitis and inflammation of the liver, and that causes edema, and which causes increase in pressure. And then obstruction, right? And obstruction of the flow would definitely increase the internal and external pressure. leading to damages, right? So when it's damaged, then all those functions that we just described a few minutes ago, it's not able to be carried on. So there's going to be a decreased breakdown of the urea, and because it is decreased, the ammonia level is going to go up, and then the patient is going to show signs of encephalopathy, right? So neurologic complications here. There's also decrease in absorption of the fat, soluble vitamins, so vitamin K, it's needed, which would decrease the synthesis of clotting factors, which will lead to bleeding. There's also decreased synthesis of plasma protein, albumin, and malnutrition and edema would occur. Next slide. So, all right, so now we're talking about diagnostics tests. First, there's always non-invasive, which is good because there's less risk that are involved with non-invasive procedures. So some of the non-invasive tests include LFTs, liver function tests. So they're going to look at the enzymes, protein, prothrombin time, and complete blood count, right? And so what you see usually, if there's a problem with the liver, there will be an increase in the liver enzymes, ALP, LDH, GGT, AST, and ALT. And there will be an increase in serum and urinary bilirubin, decrease in albumin and protein, and increase in prothrombin time, meaning that it takes longer for them to form a blood clot, which is not good. And of course, the platelet counts are lower, which tells you that it's easy for them to bleed, and it's not easy to form the plug. Next slide. All right. Next slide. Okay. So invasive tests are liver biopsy and angiography, right? So angiograms will help to visualize the artery and the vein, and the liver biopsy we're taking a sample of the tissue and then try to analyze it to see if there's any malignancy. To see if there's any malignancy here. Well, clearly, especially with liver biopsy, is we have to prepare the client before, and our preparation includes reviewing the chart to make sure that there is a signed consent on file, to withhold food and fluid, usually 4 to 6 hours, but we got to look at whatever facility that you're working at, assessing and record the baseline vital signs so you have something to compare with. You want to make sure that the patient is not, going to bleed. So we're going to review the prothrombin time and the platelet count, and then maybe administer vitamin K as ordered. We're going to instruct the client to empty their bladder immediately before they go in for the biopsy. And then we'll place the patient supine on the far right side of the bed, and then turn their head to the left and extend their arm above their right arm above their head to improve the access to the biopsy site in its right upper quadrant. All right, we're going to teach them. There's some teaching that needs to happen. So we're going to teach them about what the biopsy is for and the expected sensation during the procedure, how to hold their breath following expiration during the needle insertion, right? Because we want to keep the diaphragm and the liver high and stabilized in the abdomen cavity. We want to try, the goal is to obtain the tissue sample. Usually it requires only about 10 to 15 seconds, but there may be some pain or discomfort during this time. After that, we need to apply direct pressure to the site immediately after the needle comes out, right? And usually you put, to place pressure, we put the patient on the right side, right? So the side where the procedure was done. You may, we need to teach them that they may develop pain, in the right right shoulder, because as the anesthesia loses its effect, we have to monitor them for bleeding. We have to food and fluid. Generally we want to withhold it for about 2 hours and then after that they can resume their normal diet, and then to avoid any coughing, lifting, and straining for the next 1 to 2 weeks. Next slide. All right, so this is hepatitis is the next discussion. Hepatitis there's different types of hepatitis. Hepatitis A, hepatitis B, hepatitis C, and that's hepatitis D and hepatitis E, right? So hepatitis A is oral fecal, which means you get it, something orally that is contaminated into the mouth, or in food or in water, right? Hepatitis B is blood-borne, and you can get it through blood transfusion, IV drug users, sexual contact, hemodialysis, or hepatitis C. And hepatitis C, primarily bloodborne, through IV drug exposure. Sexual contact is low. Usually the duration of hepatitis A is 15 to 50 days, and it's communicable 1 to 2 weeks after the symptoms. Hepatitis B lives longer, right? 100 days versus hepatitis C, 14 to 100 days. Hepatitis A is usually self-limited. The patient will complain of fever, fatigue, nausea, diarrhea, anorexia, right upper quadrant pain, jaundice. Hepatitis B can become chronic, and so can hepatitis C. And hepatitis C is more progressive, and it can cause some severe problems such as cardiorenal lymphoma. Next slide. So there's a case of a nurse, of a client, and here's some previous history. They work ocean compliant officer, munitions factory, auto accident at age 16 with multiple transfusion, frequent socialization with alcohol intake, frequent intake of shellfish. So the question is, which one of the hepatitis can they are they possibly exposed to? Well, munition, that's like factory war type of stuff. Is it possible for them to expose? OSHA, is it possible for them as an OSHA compliant, monitoring chemicals? Is it possible that they expose to bloodborne stuff? Automobile accident, if they had transfusion, is it possible that they would get any one of the hepatitis? What about socialization with alcohol intake? With taking alcohol, maybe under the influence, you're not able to think right, the activities, the behavior, would that put you at risk for hepatitis? What about the fish, shellfish in particular? How does that put you at any type of risk for hepatitis? Because remember, if the water is contaminated, those things are there, and especially folks that eat sushi, raw food, that may put them at risk for hepatitis. Next slide. So there are some clinical manifestation for the client that in this case, and what is the pathophysiology cause for each of the different clinical manifestations. So why do they have confusion? Why do they have jaundice? Why do they have pruritus or chronic fatigue? Right? And you will see as we go through this different lecture, the slides, how any of this would happen. Okay? Next slide. So we're talking about the pathophysiology of hepatitis. So if the liver is damaged, there's a lot of changes that take place. So it gets inflamed, there's some degeneration. The liver is supposed to be able to regenerate, so it's going to be difficult. There's cellular necrosis, right? There's interruption of the bile flow and stone development, right? All right, so what are some of the clinical manifestations? The clinical manifestations are very similar, right? So pre-icteric, so before before jaundice. So a what the patient look like before they are jaundice, and usually pre means before. So the symptoms that the patient will present with, they usually non-specific, right? Non-specific. And so non-specific symptoms include nausea, vomiting, fever, fatigue. So other things can cause that, right? That's why it's non-specific. And then you have the icteric stage, which is here there is alteration in bile excretion. So they are jaundice. They are jaundice, icteric, right? And then you have post-icteric, right? So after the jaundice period, there is fatigue, relapses, and jaundice, right? And so generally there's upper quadrant pain, anemia, and they bruise easy and they bleed easy for all the reasons that we talked about, the function of the liver, coagulation, that role that it plays. Next slide. So how do we diagnose it? How do we diagnose hepatitis? Well, we're going to look at different, it's going to be a blood draw, right? And we're going to look at the viral specific markers. So there's surface antigen, the surface antigen that are taken, hepatitis B surface antigen, hepatitis A or hepatitis C. The surface antigen will tell you about if someone has a current infection or they're in a carrier state. And the antibodies tells you that current or recent infection, right? Or they are a carrier. So for example, core hepatitis B core antibodies. And IgM tells you an acute case versus IgG, which tells you past exposure, probably immunity, right? Either immunity from having the infection and then their body converts it, or immunity from getting the vaccine. Next slide. So the laboratory findings or tests will show you something that the liver is damaged or alteration in function. So the liver function says ALP, LDH, GGT, AST, those will be elevated. The serum and urinary bilirubin will be elevated. Remember we talked about the serum albumin and protein will be low. The prothrombin time is going to go up, and the platelet count will go down, right? Because again, you got to think about the function of the liver. Next slide. So prevention is really important, right? Prevention is really important. So we want to eliminate the exposure, right? So is it fecal oral routes? So let's make sure that we fix that. Contact with any bodily fluids or blood, safer sexual practices, and limit the mother newborn exposure. And for a mom who is a carrier, when baby's born, baby has to get the first shot of hepatitis B and of course immune globulin as well. All right, so there are vaccines. Hepatitis A has a vaccine. It's an inactivated dose of the virus, and it's usually 2 doses that is given for hepatitis A, and they are 6 months apart. All right, at least 6 months apart. Hepatitis B, there's also vaccine available for that. There's you get the first shot of hepatitis B now, and then a month later from the first you get the second one, and then the last one you get 6 months from the first. And this is one of the vaccines that we give to the newborn when they're born. If mom is a carrier, then that kid, the baby's not gonna get hepatitis B number 1, and then we add an immune globulin to it. There's no vaccine for hepatitis D. Hepatitis D, you get protected if you are vaccinated against hepatitis B. Because in order for you to have hepatitis D, you must have an active case. You must have hepatitis B. So if you get the vaccine, that automatically protects you from getting hepatitis D, because now you can't. That precursor is there. Excuse me. Okay? And so strict hand washing is the key here for transmission of hepatitis. strict hand washing, because hepatitis B can live in the surface of a door for a long time. So washing your hands when you come in contact. All right, next slide. So here's some nursing diagnosis that relates to hepatitis. There is activity intolerance, is fatigue, altered nutrition. Just think about all the things that hepatitis, the liver does. Risk for infection related to decreased immunity, remember? Risk for transmission, right? Because you're a carrier, for example, you can pass it on. Ineffective health maintenance, right? So what do you do for activity intolerance? Well, physical and emotional rest, as well as fatigue, right? What do you do if someone has altered nutrition? Well, you decrease the fat with vitamin supplements, and protein may be restricted in the acute phase. But protein actually is good because it builds a repair. But not when you have an active case. Risk for infection related to decreased immunity, so decreased exposure, decreased invasive procedures. Risk for transmission, right? And ineffective health maintenance, so patient and family teaching. Next slide. So drug therapy, because hepatitis B, you can get it and the body can convert over. Same thing for hepatitis C. However, there's a tendency for hepatitis B and C to become a chronic disease, right? 10% of the patient with hepatitis B and greater percentage with the patient with hepatitis C. So they become chronic, and meaning that they're a carrier. And so there are complications when the patient is a carrier of the hepatitis. Case in point, when the woman who has it, who is delivering a child, that kid has to be treated differently from the other kids that are born to parents or mom that do not have hepatitis B. All right. So there are some hepatotoxic drugs that they could be used to treat the condition. Alpha interferon, ribavirin, immune globulin, like I said, and of course the vaccines that we discussed earlier. Interferon causes flu-like symptoms for the patient who take for hepatitis C, so we tell them to take the medication at night. Next slide. So there are some complications. Like I said, hepatitis A and hepatitis B, the most acute cases resolve without complication. Most of the cases, they resolve without complication. But like I said, there's chronic active hepatitis B, mild, moderate, severe, right, which may progress to cirrhosis. And there's chronic persistent ones, which has a delayed convalescent period, which means a gradual period, and then the fulminant hepatitis, which is a severe impairment of the liver, and it's usually due to hepatitis B. That can lead to liver failure. So this is serious. Next slide. Cirrhosis of the liver. Diffuse, see the diffuse fibrotic brands of connective tissue in response to the inflammation. Distorted the normal shape, right? Because see, normal liver is kind of smooth, right? So it distorted the shape. So it's really, because the liver regenerates, and when it becomes cirrhotic, that ability to regenerate is gone. Next slide. So the pathophysiology, so degeneration ability is gone. So there's destruction, there's necrosis. It tries to regenerate, but when that happens, scar form, right? And this scar causes this fibrosis tissue, right, in a disorganized pattern, which leads to compression of the vascular system and the lymphatic bile duct, because the ability of the liver to drain and store and synthesize things is no longer there. Leads to alter flow. Alter flow. Right? That would lead to poor cellular nutrition, leading to hepatocellular hypoxia. Remember all the blood flow that goes to the liver? So this process is going to be hindered. So cirrhosis of the liver, it's not a good thing. Next slide. So now we're talking about the 4 types of cirrhosis. There's alcoholic cirrhosis, and it's usually due to long-term alcohol abuse. There's post-necrotic cirrhosis, which is usually from mass hepatic necrosis, usually after some type of toxic exposure, autoimmune process, or post-viral hepatitis. There's biliary cirrhosis, and it's usually due to the fact that either there's chronic obstruction of the bile ducts, or there is the flow of the bile stasis is blocked, or inflammation of the biliary system. Number 4 is cardiac. So it's usually maybe severe right heart failure, cor pulmonale, or constrictive pericarditis. So things that have to do with the heart. Tricuspid insufficiency. So many things can cause cirrhosis of the liver. Most people just think, well, they're alcoholic, and the people with hepatitis, but not really, because the bile stuff and cardiac stuff can also cause cirrhosis of the liver. And again, when the liver is cirrhotic, then the function of the liver is impaired, right? All the things that we talked about in the beginning. Next slide. So what are the clinical manifestations, which are usually, seen early, and some of them are seen late? So early, you're going to see some GI disturbances, such as dyspepsia, anorexia, flatulence, nausea, vomiting, and change in the bowel habits. And it's usually these changes are seen, because there's alteration in metabolism of the fat, carbohydrate, and protein. Right? Abdominal pain is another clinical manifestation that is early, and it's dull, heavy, usually in the right upper quadrant, pain, or epigastric. You see, remember where the liver lays, how it lays. And why does that happen? Well, for many reasons. One is the swelling and stretching of the liver capsule. Remember, spasm of the biliary ducts is one, or intermittent vascular spasm. So for every manifestation, there's a reason for it, right? So GI disturbances, because there's alteration in metabolism of the fats. Abdominal pain, because it's either swelling, stretching, spasm. It could be spasm of the biliary ducts or the vascular system. Next slide. So more other additional symptoms. There's lassitude, fever, slight weight loss, hepatosplenomegaly, so the spleen and the liver gets large, and the liver will be palpable. Later on, next slide. Later on, these are some other manifestation that you see. So now you have jaundice, skin lesion, hematologic problems, endocrine disturbances, and peripheral neuropathy. Next slide. So what are some of the diagnoses? Same liver function test that we are using before. You could do biopsy, for to find out what's causing it. Maybe there's, tumor. So the liver function test, enzyme, protein, cholesterol, protein time, and the liver may be, when you palpate it will be enlarged. Next slide. What happens with normal bilirubin excretion? So usually bilirubin, this breakdown of hemoglobin, to bilirubin, and it's converted to, it's non-water soluble, right? It needs to be water soluble so that it could be excreted. So then it's carried by a protein, albumin, to the liver for conjugation, where it is made water soluble, right? and then it can be excreted. All right, so there are tests that we can do to assess for that: indirect bilirubin, direct bilirubin. Bilirubinogen is the breakdown of conjugated bilirubin that is excreted in the urine in small amount in the feces. Right? So this is what normally happens. Unconjugated and conjugated bilirubin. Right? So it's not water soluble, it needs to become water soluble. And so the liver helps in that process. And so when the liver is bad, it's not going to be able to break it down so that it can be excreted. Right? Next slide. So unconjugated indirect bilirubin is overproduction. It's usually due to hemolysis, impaired hepatic intake, impaired conjugation, right? Versus conjugated bilirubin, and it's usually due to impaired excretion of it from the liver disease, right? So drugs, sepsis, diseases can cause this problem. Next slide. So red cells, it's breaking down. Bilirubin is formed. It joins with albumin to become unconjugated in the bloodstream to liver. And the liver bilirubin releases from the albumin, combines to conjugate in small amount, right? And then it enters the intestine, right? The intestine, bilirubin converted to urobilirubinogen, right? And it's excreted through the kidneys and then excreted to the stool, normal. It's a normal process. Normal process. Next slide. So what are some of the tests, the lab tests to show abnormalities of cirrhosis? Similar tests you've already seen, because it's the liver we're still talking about, right? So it will be increased abnormal levels of the liver. The serum bilirubin is going to go up because remember it's supposed to excrete through the urine. It's not. The platelet count is going to go up. The PT goes up, platelet goes down, because PT is the length of time it takes for blood clot to form. And since the liver is not working well, it's going to take longer for that to happen. Platelet count go down, putting them at risk for bleeding, right? The serum albumin protein level goes down. Same things, right? Next slide. So jaundice, what is jaundice? Right? Is yellowing, right, of the skin. And for some people, it's not easy to be seen like they're dark skin, right? So you have to look at areas that you can see a change, like your mucous membrane, your sclera. So it is the inability of the liver to conjugate bilirubin because it needs to be converted, right? So sclera, skin and sclera show jaundice. You excrete it in the urine, you're going to see tea-colored urine, right? And because of the blocked of flow into the intestine, you see clay-colored stool. So high level of bilirubin is called hyperbilirubemia. Next slide. So see the sclera? So what changes do you see and why? We just went over that. For the skin, what do you see? Urine, what do you see? Stool. So skin, you see jaundice. Urine, tea-colored. Stool, clay color. And why? Just talked about that. Next slide. So what do you see with the skin? Small dilated blood vessels. Palmar erythema with blenches, and all this is happening because there's increased circulation of estrogen due to a decreased ability of the liver to metabolize steroids. Next slide. Hematologic changes. Thrombocytopenia, leukopenia, anemia. Due to the spleen, splenomegaly, there's backup of blood from the portal vein into the spleen. Overactivity of the enlarged spleen, which increases the removal of cells from circulation. And then you see coagulation defects. So because the liver is not able, doesn't have the ability to produce the pooled thrombin and other clotting factor, or because there's decreased synthesis of the bile salts, absorption of fat, soluble vitamins. So without vitamin K, clotting factor production is less. You understand that? Next slide. You see endocrine problems too, right? So gynecomastia, loss of axillary pubic hair, testicular atrophy, and decreased libido because there's hyperaldosteronism, right? So there's increased sodium, increased water, and decreased potassium. Next slide. Peripheral neuropathy is also a complication. It's also so mixed form, sensory predominant. So diet that is low in thiamine, folic acid, and vitamin B12. Next slide. Complications of cirrhosis include portal hypertension, esophageal varices, hepatic encephalopathy, ascites, peripheral edema, and hepatorenal syndrome. Let's talk about each one of these. Next slide. So portal hypertension of esophageal varices initially occur because of compression and destruction of the portal veins, hepatic veins, right? Obstruction leads to obstruction of normal flow, the portal system, which increases the temperature. And then because of that, because of this increase in blood pressure, there's collateral circulation that develops. So now, the body's trying to find an alternative pathway. So, which leads to the portal pressure, plasma volume goes up, lymphatic flow obstruction, leading to lower esophagus, more pressure, collateral circulation develops primarily in these other areas, the rectum, the abdominal wall. So the pressure, the builds up, the burgeon. So you're going to see that. Okay, so bulging. Next slide. So this collateral circulation due to the portal hypertension, it leads to this bulging things, the varices. It could be varices in the esophagus, in the abdominal wall, or in the rectum. If it's in the rectum, that's what we call hemorrhoids. If it's in the lower esophagus, we call them esophageal varices. If it's in the abdominal wall, we call it caput medusa. So caput medusa is like a tree-like sign appearance, so you have a distended and gorge superficial epigastric veins that radiate, that forms like from the umbilicus, and it kind of spreads across the abdomen. It looks like Medusa. All right, so these are dilated varices, right? And it's all because of the portal hypertension. Next slide. So individuals with varices, esophageal varices for instance, there's increased risk for bleeding because the varices are fragile, elastic, thin wall, right? They become distended, and if irritated, they can lead to rupture. And there's many things that can irritate it: alcohol, medication, gastric reflux, vomiting, all right, or trauma. Like if we're putting, NG2, they're vomiting, or poorly chewed or coarse food that irritate that area. All right, it will lead to increasing esophageal pressure, other things that can cause it. So vigorous exercises, somebody's coughing, sneezing, straining at stool, all those things can cause an increase in the pressure, therefore causing a bleed. So esophageal varices is not a good thing because, these fragile veins can rupture. Next slide. So the key is to manage it and prevent it from happening, right? Prevent from happening, manage it, and prevent recurrence of hemorrhage. So those are the three things you're going to do. So let's talk about how each one of those is going to be met. Next slide. So preventing it is to giving them, because of that portal hypertension, we're going to give them things to lower it, right? So beta blockers, that would help decrease the portal pressure. All right, stool softeners, so they don't have to strain, H2 blockers, proton pump inhibitors, you know, and diet modification, so no alcohol, caffeine, spicy food, and coarse food. Next slide. We're going to manage acute hemorrhages. So 65% to 75% of people that have cirrhotic develop some esophageal varices. That's a pretty high number. And rupture varices have a 30 to 60% mortality rate. Right? So pharmacological management, vasopressin, endoscopic injection of drug therapy, sclerotherapy that would stop or burn the area, balloon, tamponade. Remember I talked about inflating a balloon and then inflating it so that it applies pressure to that side. All right, and then supportive therapy, fresh frozen plasma, giving them red cells, vitamin K, H blocker, and neomycin. Next slide. So what are some nursing diagnoses? So impaired gas exchange related to decreased oxygen exchange secondary to many things, aspiration, airway obstruction, you know, usually occurring after the balloon tamponade. Aspiration pneumonia, so making sure we suction the patient frequently. They may have nares erosion, so the tubes that goes in the nose, so clean and lubricate them and pad if necessary. Airway obstruction. Next slide. So preventing recurrent hemorrhage is usually done by placing shunts, which would decrease the pressure, divert the flow away from the collateral channels, right? Complications itself are hepatic encephalopathy, heart failure, bacteremia, and the shunt that's going to clog. Next slide. This shows you the TIPS procedure, so show you how our main job here is to make sure that the shunt is easily accessible or flows very well. Next slide. So they are complication of the shunts, right? Post-operatively, you're concerned about, is it going to form clot, right? So we're going to assess for pain, distension, and nausea. That's how you're going to know if it's not draining. Next slide. Fluid volume excess is another nursing diagnosis, and that is related to the retention of fluid secondary to many things such as portal hypertension, liver failure, hemodilution. And so the outcome is to normalize the fluid, right? So we're going to stabilize or decrease abdominal girth, right? So you can measure the abdomen, right? Regular respiratory rate and rhythm on labored breathing, and then the output will be greater than the intake. So what are the intervention? So abdominal girth measurement, weighing the patient, between the eyes and nose, assessing for edema. All right, pulmonary edema, so look for dyspnea, orthopnea. Next slide. So post-op complication, hepatic encephalopathy, so you know that because there's increasing ammonia level, the bilirubin level, and the liver enzymes. Heart failure, the shunt would increase preload. Hemorrhaging, so we're going to check H&H and pour time, pour thrombin time. Other labs, we're going to look at the kidneys, the BUN, electrolyte, and serum protein. And we can anticipate that they may need transfusion, vitamin K, TPN, or albumin IV to try to pull the fluid back into the intravascular space. Next slide. So ascites is another complication, and so for the intervention for that, ascites is the protein leaks through the liver capsule to the peritoneal cavity, and so it leads to the oncardic pressure to pull the protein more fluid. So more fluid is pulled, decrease albumin, so the fluid is leaving, albumin is not in the blood anymore, right? So the liver's inability to synthesize the protein, drops the oncardic pressure and increase the aldosteronism due to the liver inability to metabolize aldosterone, right? So when it's not able to do so, there's an increase in sodium reabsorption, which increases serum osmolality, which increases ADH, antidiuretic hormone secretion, which also increases water retention. So clearly the abdomen is large, so we're going to measure and assess, a better position of comfort. It's increased Fowler's position. We want to decrease the protein and decrease the salt intake. Mouth care, dehydration, potassium sparing diuretics, paracentesis, right? So removing the fluid, and salt poor albumin, right, to help pull the fluid back in the space. Next slide. Ascites and peripheral edema. So there's portal hypertension, and the protein and plasma leak into the peritoneum. Again, the oncardic pressure pulls more fluid in, and then you end up seeing low albumin in the blood. And again, there's hyperaldosteronism, right? So increasing ADH. Next slide. So the goal is to decrease the metabolic demand on the liver, and of course treat the complications that may occur. So we're going to balance the fluid volume. We're going to make sure that there's no breathing problems. We're going to correct any coagulation defect. We're going to make sure that they don't have any infection, and make sure they have adequate nutritional intake. So that's the goals and the outcome. Next slide. So systemic portal encephalopathy. So here what you have is, again, buildup of the ammonia level in the central nervous system, cerebrospinal fluid, which leads to neurotoxicity. And when there's toxicity in the brain, you see signs and symptoms that tells you that the brain, there's something wrong. So altered level of consciousness, impaired thinking, neuromuscular disturbance. Early signs include change in handwriting, right? Treatment is neomycin and lactulose to help bind and excrete the ammonia level through the GI system. Next slide. So the hepatorenal syndrome. So you have a buildup of BUN, or you have a buildup of so azotemia, which is a buildup of nitrogen kind of containing base stuff such as BUN, creatinine level. So that builds up. So you see that in hepatorenal syndrome. You also see sudden oliguria, right? Because renal oliguria, or intractable ascites. All right. So what we want to do is to redistribute the blood from the kidney to the peripheral, and you see hypovolemia due to ascites, and you see intrarenal imbalance of vasoconstriction and vasodilation mechanism due to the liver disease. Right? Next slide. So what are the risk and management? Well, precipitants are overly vigorous diuretics, GI, and variceal hemorrhage, paracentesis, hepatic encephalopathy, and certain sepsis. And so what we're going to do, we're going to give them salt poor albumin, restrict sodium and water, and give diuretic therapy. Next slide. Alcohol withdrawal symptoms is usually seen 48 hours to 72 hours after the last drink. It's a hidden disease. It's a potency and antidepressant. Alcohol is. Withdrawal awakens the central nervous system. Untreated or undertreated, can lead to many problems, mortality and mobility. DTs, or delirious tremors, can be life-threatening medical condition. So what are some of the clinical manifestations that somebody's in withdrawal? Tremors, shakiness, increase in vital sign, they're diaphoretic, they're agitated, there's confusion, there's sleep disturbance, hallucination, and seizures. So we should anticipate problems if we suspect DTs. Next slide. So the goal is to decrease the patient discomfort from all the side effects, decrease dangerous clinical manifestations, prevent the complication, and prepare the patient for rehabilitation. They have to be ready for rehab, right? And consider the primary diagnosis. So what is causing them to be in the current state? Submissions, assessment, frequent monitoring, promote and adequate treatment, benzodiazepine. It's really important. Safety, because they are agitated, to make sure that they're safe. Seizure precaution. Okay, next slide. All right, so I missed the slide about hepatocellular carcinoma. So hepatitis B, hepatitis C can cause liver, right? So the liver cancer generally, just like any other cancer, abnormal proliferation, there's many ways to try to treat, right? So you can do surgery, you can do chemotherapy, you can do palliative care, or there is transplantation, especially for cirrhosis, all right? So surgical resection, it could be a lobectomy, a hepatectomy, right? Chemotherapy, so we can portal vein or hepatic artery perfusion. Palliative is usually saying, for cirrhosis as well. Transplantation, so individuals with cirrhosis due to hepatitis viruses. And if it's transplant, it's also good if the cancer is only situated in the liver. Another reason for transplantation is congenital diseases of the liver. So now we're talking about the biliary tract, the gallbladder, the cystic duct, hepatic duct, and the common duct, right? Next slide. So what is the function of the gallbladder? It's located in the right upper quadrant pain. Usually one of the reasons why you have main reason why you have right upper quadrant pain. It concentrate and store the bile produced by the liver, and the bile release is stimulated by the presence of food in the GI tract. Next slide. So what are the disorders of the gallbladder? There's cholelithiasis, and it's usually due to cholesterol, bile, and calcium stool formation, and cholecystitis, which is an inflammation, an obstruction of the gallbladder, so usually due to stone or bacteria. Next slide. So what are the clinical manifestations? There's usually indigestion and fat intolerance. So you see fatty stool, diarrhea. There's moderate to severe pain. Usually they refer to the right shoulder and scapular, biliary colic pain. They are nauseous and vomit. There's increased temperature in WBC. There's jaundice, there's dark urine, clay-colored stool, pruritus, and bleeding tendency. Next slide. So how to diagnosis? We take a nice history, ultrasound, can do cystograms, percutaneous, transhepatic imagery, ERCP, and that would look at the gallbladder, biliary, pancreas, and the liver. And then of course lab tests that show you elevation in direct and indirect bilirubin and elevated liver test, AST. Next slide. As previously we talked about the normal breakdown of bilirubin excretion, and that doesn't change. And so when there's a problem with the gallbladder, this process is going to be affected. Next slide. So what is the treatment? Well, it depends on what it is. Cholecystitis and inflammation, so we try to control the pain, control nausea, vomiting, antibiotic, NG2 diet, restriction of NPO, anticholinergics, fat-soluble vitamins. And in cholelithiasis, we want to dissolve the stone, right? And do a shock wave, ESWR, WL. Shock wave therapy, and part of the job, like the kidney lecture, is to make sure that we monitor, strain the urine so we can see if the stone is passed. All right, next slide. So laparoscopy, or open or incisional cholecystectomy, and more complicated. But laparoscopy surgery is what's generally used. Next slide. So this is showing you how small invasive site to address the situation. Next slide. This is just another image showing you the cut-in episode. Next slide. Post-operative care, so laparoscopy, so management of pain is really important. Sims position, encourage mobility, cough and deep breathing exercises, and discharge teaching about activity and diet with an open incision, which is bigger surgery. So pain management, again, similar things, mobility, cough and deep breathing, wound care. This time we need to make sure we monitor the T-tube monitoring, and of course teaching them about activity and diet as well. Next slide. All right, so care and teaching for the T-tube. So you want to keep the bag level below the abdomen, prevent any tension, so don't pull on it, monitor urine, monitor the skin site, clamp 1 to 2 hours before and after, and then unclamp 1 to 2 hours after, and then clamp if there's distress, right? And it's usually there for approximately 10 days. This ends the lecture of this section. Patient with hepatic biliary dysfunction. Thank you.